Okay.
Good. We can see your.
Can you see the whole screen? All the
Yes,
screen?
I see the PowerPoint presentation. But it's not the slide, not on the whole screen.
Okay, okay. Now is the whole screen now?
Now very good.
It's okay now?
It's okay, it's great. Excellent.
Okay.
You can start.
Okay, thank you very much. Now I am going to speak about thoracic and lumbar spine anatomy. So for the understanding of this topic, it's very important to make some exercise, taking some measures about the lumbar spine and also thoracic spine. Now, in this slide, we can see a model of lumbar spine and some measures. For example, in here, I am doing the measure of for example, okay. In order to understand anatomy of the lumbar and thoracic spine, it's also very important to see the anatomy of the spinal cord. And this slide is very beautiful because I can show you the vein and arterial anatomy. So I took some measures about the pedicle of this. For example, this is a vertebra in L1. This is a non-degenerative, and as you can see here, I take the measure of this L1 is about 8 millimeters. The canal, the spinal canal is in here is about 20 millimeters. In this case, the anteroposterior is about 17. And this is the plate of the vertebra. This is about 44 millimeters, and this is 26. So it's important to know these measures, because when you want to put a screw into the pedicle, this is a very important measure. For example, in here we have L2, a non-degenerative spine. This the width of this pedicle is about 12 millimeters, and the lamina is about 18 millimeters in here. So I took the measures of all the lumbar and thoracic spine and non-degenerative and degenerative spine. So let me show you. I have been doing some exercise in taking or removing the spinal cord. For example, in this, for example, spinal cords were extracted via longitudinal midline posterior incision from the occiput to the sacrum. Anatomic dissection was performed until reaching the vertebral lamina. Laminectomies were performed from C1 to L5, and the spinal nerves were cut with care so as not to lesion the dura. Here we have this spinal cord covered with dura mater. And to show the spinal cord, red natural latex was injected into the Adamkiewicz artery under moderate pressure and close visual inspection to avoid contrast extravasation. The injection was continued until latex filled distal small caliber arterial vessels, including the posterior spinal arteries. Veins were injected also with blue natural latex. Here is this exercise in order to get some skills about vascular anatomy. The great anterior radiculomedullary artery is located in the anterior aspect of the spinal cord, where it took a characteristic hairpin. The preoperative localization of this artery is very important in the surgical transthoracic spine procedures. Here we have this beautiful artery, Adamkiewicz artery. This artery is a left-sided vessel was present in 45 specimens and a right-sided was present in 5 specimens. This is in the right side and this is in the left side. This is the aspect of this artery running in the anterior aspect of the spinal cord. Although variability exists to the overall caliber of radiculomedullary arteries, dominant radiculomedullary arteries are present. The most important is the Adamkiewicz artery, and the origin of this artery is between T8 and L2 in 75% of patients and has a diameter less than 1 millimeter. So this is the aspect, the lateral aspect of this artery. As you can see, this is really, really beautiful picture about the end of a spinal cord. This is the conus medullaris, this one, and here we have some veins and these small arteries. This is the Adamkiewicz artery, and in the superior view, here is the thoracic artery. So in order to understand the insertion of the screw in the pedicle, I took this picture in order to see the direction of the screw. As you can see here, we have a 10 or 15 grades to put the screw into the pedicle in the lumbar. And this is a lateral view in order to see the direction of these screws. Here we have some other measures about the dimension of this pedicle. This is L5, a non-degenerative L5 lumbar vertebra. Here we have 23 millimeters. Is very, very good to put a screw. And the lamina is short. Here we have the dimension of the spinal lumbar canal. This is 26 millimeters, and the plate is about 54 millimeters. And the anteroposterior measure is about 30 millimeters. So here we have another picture about this bone. So the sacrum is a name given to the triangular bony mass made by fusion of the five sacral vertebrae. It has a superior base that articulates with L5 and inferior apex that articulates with the coccyx. Concave ventral deep surface that forms the posterior superior wall of the pelvis, and a convex dorsal superficial surface that is palpable beneath the skin. This is a video, and I want to show you. I think this video is good.
To localize the entry point of the sacrum,
we first go to the inferior part of the facet of superior articular process, and then to the posterior sacral foramina. In the middle of this imaginary line, we have the entry point. And then the direction of the screw is 15 or 20 grades superiorly, and then medially, again, 15 or 20 grades in order to go to this wide part of the sacrum. The entry point of the lumbar vertebra is an imaginary line horizontal to the transverse process, and inferior just below the facet, articular facet. In there, we have the entry point. This is in this video. I show you the basic knowledge about to insert and screw into the pedicles. The thoracic vertebra, the vertebral bodies resemble cylinders with concave side walls and nearly equal anterior, posterior, and transverse dimension. The T1 and T2 bodies shows flat anterior faces. The T3 body is the smallest thoracic vertebral body and shows a convex anterior surface. From T4 downward, the thoracic vertebral bodies become progressively larger to bear increasing weight. The two thoracic pedicles extend directly posteriorly from the vertebral body, nearly parallel to each other, rather than angling posterolaterally as do the cervical pedicles. The thoracic pedicles increase in size progressively from above downward. In this slide, I am showing the T1 non-degenerative vertebra. Here we have this measure of the vertebral body, and then the spinal channel. Here is about 20 millimeters. The plate of anterior-posterior is 25 millimeters. This is the second T2, and this is the channel. This is the pedicle is about 9 millimeters. This is in non-degenerative. Later, I'm going to show you that in some degenerative thoracic vertebra is only about 3 millimeters wide. So in that case, it's almost impossible to put a screw because of the pedicle is very, very thin. Thoracic laminae are short, thick, and wide. From above downward, they overlap each other like shingles of a roof. Thin superior articular processes arise from the junctions of the body with pedicles, extend mostly superiorly, and display flat facets that face mostly posteriorly. The inferior articular process project caudate from the inferior margins of the lamina and display facets that face predominantly anteriorly. The paired superior articular facets lie closer to the midline and to each other than do the paired inferior articular process. Here we have T1 degenerative. This is, as you can see, this is only 12 millimeters in this part of the spinal canal, T4, and here we have this measure 13 millimeters. Let me show you the thoracic artery. This was present in 38 spinal cords, 32 in the left side and 6 in the right side. 2 spinal cords did not have thoracic artery, most frequently in left T4, followed by left T3. This is a beautiful picture about the thoracic artery. This arises from right side, and this arises in the left side. Here we have the spinal cord in the thoracic segment of the spine. A small thoracic artery, this is a very small thoracic artery. The narrowing of the thoracic segment of anterior spinal artery has an average diameter of only 0.13 millimeters. 0.13. This is 0.17 to 0.53 millimeters. These measures was always done at the thoracic 5 level. Now here we have the 4, 5, and 6, 7, and 8 measures about the pedicle. This is about 5 millimeters. In the 5th vertebral is about 4.7, almost 5 millimeters wide. This is 6. This is almost 7. And this is 13 in the, this is the canal. Pedicles are here. So this measures is about the sacrum. In these pictures we have almost this thoracic artery. This is, I want to show you an exercise in a cadaveric specimen in order to see this lateral, an extreme lateral interbody fusion. This is an exercise in cadaveric specimen. This is we open this lateral aspect of the spine in order to see much better the work, doing this removing of lumbar disc. So here we are doing this exercise. And then to put this, doing this interbody fusion. So now again, we have these measures of this degenerative spine. This is T8 and this is L1. Then we have another measures of non-degenerative spine. And let me show you the thoracic pedicle screw placement. Video, we have the 4 thoracic vertebra. I prepared this bone. This is made in a scale 1 per 1, and doing this, we can make some exercise to put the correct insertion of the screw in this thoracic vertebra. So this is 4, 5, and 6 vertebral thoracic segment. 5th and sixth. This is the lateral aspect. And then let me show you the dorsal aspect, the spinous process, and then the dorsal aspect. Look the transverse process, the lamina, and spinous process. Meticulous dissection and exposure of the transverse processes should be performed. Cartilage should be resected. The most important anatomic landmark is the middle of the facet. I'm going to separate these 4 vertebrae in order to show you the facet. This is the facet, this one, and this is the middle of the facet. As the pedicle screw, the start point should always be lateral to this midpoint. So here we have the medial of the facet, and the entry point should be lateral, a little lateral. Here it is. The base of the superior articular process is a key landmark. The base of the superior articular process for entry into the pedicle. The starting point for each thoracic screw varies. It is best to place the screws parallel to the superior end plate. So, in here, I enter parallel to the superior. When the procedure is started distal at T12, there is a trend toward a more medial and cephalate pedicle starting point as one proceeds toward the mid-thoracic region, T78. Proximal to this point, like in this case, the starting point moves more lateral and caudal as one proceeds to the upper thoracic spine. So as you can see in this is 5 thoracic. This is a little superior, the direction of this one. Video. Then a burr may be used to create a pedicle blush by removing only the dorsal cortex in the area of the targeted pedicle entry point. A pedicle blush refers to bleeding that arises from the vertebral body into the pedicle start point, and with gentle ventral pressure, the gear shaft should be easily wiggled into the pedicle. So let's go to see this video. And as I told you, the pedicle is very, very thin, about 3 millimeters in this degenerative model of thoracic vertebra. So it's almost impossible to preserve this pedicle because this is very, very thin, just about 3 millimeters wide. So look what happened when this pedicle is very, very thin, like in degenerative thoracic vertebra. In the other side was almost the same. This lead line is about 3 millimeters wide. So The surgeon then probes the pedicle hole to feel for the medial, lateral, superior, inferior, and ventral walls of the pedicle. Most pedicle violations occur at the junction of the pedicle and vertebral body. The potential pitfalls, pedicle violation medially or inferiorly may occur and result in nerve root or spinal cord injury. Anterior cortex violation from screws that are too long may result in vascular or visceral injury. Pedicle screw pull-out or failure of fixation may occur with malpositional pedicle screws. So we have to take in mind that this spinal cord is the queen of this kind of surgery. We have to preserve all the functional and anatomical integrity of the spinal cord. Let me show you this dissection. Here we have the cauda equina, and I separate these nerves in the cauda equina, and I am seeing here these veins. Here we have the anterior aspect of the spinal cord, the Adamkiewicz artery, doing some loops in its trajectory. Let me go. This is a very small ligament, very small, very thin ligament that preserve the direction of this Adamkiewicz artery. The lateral aspect of this spinal cord and the dentate ligament. Okay, and here we have the great spinal anterior vein. Some pictures about this venous anatomy of the spinal cord is also very useful in order to preserve the anatomy of the spine. So this is my lecture. Thank you very much for inviting me. It's a big honor for me to be here with you. So in order to understand anatomy, it's very important to make dissection of the spine. It's very useful to get some skills, surgical skills. So I feel really honored to be with you. Let me tell you that at some hours before, I had some problems with my computer, especially to put some videos. So I thought that my lecture was going to be 8 or 10 hours more. So no problem. Here is my lecture. Thank you so much.
Fantastic lecture. We all have learned a lot from it. And thank you for your participation.
Thank you, Ahmed. Thank you so much. Thank you.
We have here